is patients presenting with UTI, repeated UTIs, chronic UTIs. Patients who present with dysuria, that's painful micturition. Trauma, especially to the pelvis, you want to evaluate the bladder and the urethra. Urinary incontinence of a known cause, you want to check for any bladder issues or bladder problems or pathologies. Patients presenting with bladder outlet obstruction of whichever cause, whether it's due to urethral strictures or even BPH suspected, you will do an MCU. Patients with hematuria, you also can be sent for MCU depending on the other clinical findings. Then postoperative evaluation of genitourinary tract, maybe patients who've undergone prostatectomy or urethroplasty. Of course, you'd want to check out the bladder or the urethra by using MCU. Contraindication to MCU is active UTI. You're not supposed to do an MCU when the patient is actively sick with a UTI, because you might worsen the infection or even make it ascend all the way to the kidneys if it's bladder, like cystitis. Meatal stenosis in boys or valval adhesions in girls are a contraindication to MCU, because you'll not be able to catheterize the patient, since you need to catheterize the patient before you do the examination. Another imaging modality, I'll show you images of all those that I've listed, is IVU, referred to as intravenous urography, or also known as excretory urography. It's a radiographic studies of the renal parenchyma, pelvic calyceal system, ureters, and urinary bladder. This is where contrast is introduced, IV contrast is introduced via a peripheral vein. Then plain abdominal radiographs are taken at different times, between 2 to 15 minutes, so that can be able to assess the function of the kidneys, all the way from a nephrographic phase where the kidneys are opacified by the contrast to the time they're excreting the contrast, up to the delayed phase when the contrast is seen at the pelvis where the bladder is. So it shows us the function and maybe anatomical location in some way. CT urogram, it has replaced IVU, because this also you give contrast, of course. It's a contrast enhanced CT of the abdomen, which will show mainly the kidneys. The advantage of CT urogram is that it will give you both anatomical and functional information at the same time, as opposed to IVU, which will just give you a functional information, but you'll not be able to see the kidneys in 3D or cross-sectionally like CT. MR urogram, rarely done, because CT urogram will have sorted the issue. It's commonly given to patients who are allergic to contrast and they actually need to be evaluated the kidney function. You will do an MR urogram, or pregnant patients who have the same issue, maybe renal function is altered. You'd want to see how their kidneys are functioning, you'll do an MR urogram. Contraindication, of course, to CT urogram is any known case of previous acute reaction to contrast. You will not give IV contrast, whether it's IVU or CT urogram. These are abdominal radiographs, plain abdominal radiographs, which are for KUB or evaluation of the kidney. Please remember, even as you do the KUB radiograph, it's the same as a normal AP radiograph of the abdomen. So you remember the AbdoX acronym that I gave you last week. You just use the same to evaluate. The first one is a normal AP or an erect AP abdominal radiograph, which was normal. The second one, you can see there's a calcific focus around the region of the kidneys. You can see the kidney here, the silhouette of the kidney right here. That's the left kidney, that's the right kidney. And this was seen to be a renal calculus of a patient who was having renal angle pain. This is an ultrasound of the abdomen, the region of the kidney. You can be able to pick kidney adjacent to the liver. Usually the kidney has a central fatty sinus, which you can see is very echogenic as opposed to the cortex, which is darker, hypoechoic. And the cortex should have the same echogenicity as the liver. That's how you'll know that the kidney has a normal configuration, and echogenicity. Same, different settings, but the kidney showing the central sinus with fat, and then the cortex having the same attenuation or echogenicity as the liver. This is an ultrasound of the pelvis showing us the urinary bladder, well distended with urine, with a normal looking smooth outline of the wall. You can be able to pick any structure within the bladder intraluminally, whether it's a mass or a calculus. And you can also be able to evaluate the wall of the bladder using an ultrasound very easily, as long as the bladder is full. These are images of a micturating cystourethrogram. It's a male patient. So we usually do a serial images of when you are filling up the bladder. You have to take an image of a full bladder so that you can be able to, after you've catheterized the patient, of course, you can see there's a filling defect here, and that's the balloon of the catheter, but you can still see the catheter all the way within the urethra. So you take a PA or an AP radiograph at that time of screening to pick a full bladder. At that time, you're evaluating for any filling defects, which could be masses or calculi. Then you check out the outline of the urinary bladder wall for any diverticuli or any outpouchings. You can also be able to pick any reflux at this time as you fill up the bladder, because ideally contrast should not leave the bladder retrogradely towards the ureters. So this is the time you actually pick any reflux as you fill up the bladder. Then after you fill the bladder to capacity, depending on the age of the patient, because pediatric urinary bladders, of course, have a smaller capacity compared to the adult bladder, you tell the patient to turn on the side or obliquely so that you can be able to evaluate the entire penile shaft. This is a male patient. Then you ask the patient to urinate. During micturition, that's when you'll be able to see the urethra being opacified with contrast. You can be able to pick any area of narrowing, any area of leakage of contrast for you to pick the pathology that you're suspecting. Because any case of strictures can be picked on this examination, or even trauma to the urethra with the leakages of contrast will be picked at the same time. So after the patient you micturates, after you pick your pathology or a normal urethra, you let the patient completely empty the bladder, then take the last image, which is an AP again, to check for a complete emptied bladder, which is ideally the normal state. This is the same procedure, but for a female patient, you can see the orientation of the urethra as opposed to the male urethra. Usually the male urethra is long, of course, up to about 15 to 17 centimeters, and the female urethra is about 4 centimeters. So when you're doing an MCU on a female, you will not ask them to turn on the side because it will not help because of the length or orientation of the urethra. Just ask them to micturate while they're supine on the examination table so that you can be able to evaluate the urethra right here. Full bladder, check for any filling defects, bladder wall outline, any outpouchings, any reflux, then ask the patient to micturate, check for any reflux again, check for the urethral appearance. That's the MCU. Then ascending ureterogram is done only in males. This is done to assess the anterior urethra if you're suspecting a stricture or a narrowing of the urethra. Here you don't catheterize the patient, you just put a catheter or a tube at the shaft of the penis, at the penile, at the urethral meatus or the meatal opening. Push contrast retrogradely so that you can be able to opacify the anterior urethra, check for the caliber of the urethra, and for any filling defects or any cases of leakage of contrast, especially for patients who are post-trauma. IVU, told you it's a procedure where a patient is given IV contrast. Then you wait for the kidneys to excrete the contrast. you'll be able to pick the contrast within the pelvic calyceal system all the way to the ureters and later to the bladder. So this will be able to show you that the kidneys are functional by the fact that there's excretion of contrast, number one. And number two, you'll be able to confirm that the anatomical location of the kidneys is normal, because if there's no opacification at the region of the renal angle, then you'll know either it's an ectopic kidney or it's a non-functioning kidney. So these two are normal functioning kidneys. You can see the ureters normal in caliber, the bladder is filled very well. Second case, you can see the right kidney, well opacified pelvic calyceal system and the ureter, but you're not able to pick any opacification on the left. But if you look keenly, you can see some dense appearance right there overlying the pelvis. And this was a normal functioning kidney, but the location was not the usual location. So this was a case of an ectopic, well-functioning kidney. So we go to the pathologies. We look at hematuria and the different causes of hematuria, blood outlet obstruction, vesicoureteric reflux, and lastly, we'll check out infection, that's pyelonephritis and cystitis. Hematuria, the first one, occurs when blood enters the urinary collecting system and is excreted in urine. This can be frankly seen, which we refer to as frank hematuria, or it can be microscopic, which is just picked from the laboratory. Origin of hematuria can be either from the kidneys, ureters, bladder, or urethra, anywhere within the renal system. And it can be caused by different etiologies, can be due to infections, can be due to tumors anywhere within the urinary tract, or patients with renal calculi, that's urolithiasis. So imaging, plain KUB radiographs and ultrasound remain initial imaging modalities of choice for evaluation of a patient presenting with hematuria. The disadvantage of KUB radiograph is usually very non-diagnostic or non-specific. Unless there's a calculus, that's about it. You may not be able to pick any other cause of hematuria. So it's very non-specific and non-diagnostic. The first cause of hematuria that we're going to look at is urolithiasis, which refers to presence of calculi anywhere along the course of the urinary tract. Main clinical presentation is abdominal or renal angle pain. The patients will also present with renal colic, especially when a stone is trying to pass through the pelvis or the ureters. They can also present with hematuria, but at times it's usually an incidental finding, so patients usually are asymptomatic. Main complications of urolithiasis is infection, that's pyelonephritis. Imaging of choice, KUB is the initial modality, but very non-specific. So we usually go to ultrasound, which is diagnostic, very effective in detection of hydronephrosis in cases of obstructing calculi. Disadvantage of ultrasound is that small stones are difficult to detect on ultrasound, especially if they are around the pelvis, and the pelvis is close to the renal sinus, which is very bright. Calculi are also bright on ultrasound, so you might miss out if the stone is very small because of the similarity in the attenuation or the cogenicity of the calculi and the fat around the renal sinus. CT urogram or CT scan of the abdomen, usually for suspected renal calculi, usually do an enhanced CT scan of the abdomen and pelvis, which now has become the first-line modality of choice because of a sensitivity of over 95%. Advantage of CT is that you can be able to get the diagnosis and also be able to get any other cause of the abdominal pain or hematuria that might mimic renal calculi. At the same time, you'll be able to get a good anatomical evaluation of the entire urinary tract when you do a CT scan. So these are plain abdominal radiographs of different patients. The first patient had renal angle pain bilaterally, but you can see multiple calcifications around the renal angles, and these were seen to be renal stones. Second patient also presented with hematuria. Plain abdominal radiograph showed multiple calcifications within the pelvis, and these were bladder stones. This is a different patient an abdominal ultrasound of focused around the kidney. You can see the right kidney, the liver. You can see a hyperechoic structure within the renal pelvis, but you can be able to see the shadowing posteriorly, consistent with the renal stone because of the fact that there's a shadow. Fat will not cause shadowing, but if you see a hyperechoic structure next to fat with posterior shadowing, that's the dark shadow behind it. That's confirmatory for calculus. Same here, different angle of the probe. These are CT scans of the abdomen. This is an axial view. This is a coronal plane. Soft tissue window, bone window. You can see there's no contrast within the aorta, so it's an uncontrast enhanced. And here you can be able to see the left kidney, right kidney, but you see calculi within the left kidney, easily picked on CT. And at the same time, you can be able to evaluate the anatomical outlook of both kidneys and the rest of the structures around. Advantage of CT. Coronal bone windows brings out the calculi very well. You can be able to count them, measure the size, and also measure the Hounsfield units or the density, because that's what the surgeons usually want us to do for them. So we go, MRI has no role in renal calculi, so it's not indicated. We go to renal cell carcinoma, another cause of hematuria. Renal cell carcinoma is a common malignant renal tumor. The clinical presentation, usually it's a triad where the patient presents with macroscopic hematuria, which occurs in 60% of cases, flank pain, and also a palpable flank mass, especially if it's a very big tumor. Imaging, ultrasound is frequently requested as the initial modality for patients presenting with hematuria, but it's very nonspecific for renal cell carcinoma because it has a limitation in locally staging the tumor. CT scan, contrast enhanced, remember. For calculi, you don't need contrast, but for renal masses, you need CT scan of the abdomen with contrast, which is used to diagnose and stage the tumor at the same time. And on CT, we see it as a soft tissue mass that enhances on post-contrast scans. MRI is also good for renal cell carcinoma. It's good in staging, which can be done on CT. And the advantage of MRI over CT is that you can be able to predict the histological type of the tumor by just the fact that the tumor will look in a certain way on T2 weighted images. So we just look at the T2 characteristics and you'll be able to predict the histological type of the tumor. That's the only advantage. But ideally, CT scan will be able to diagnose for you. It will show you the tumor and it will state the tumor for you. So we'll just wait for maybe histological biopsy. This is an ultrasound focused at the region of the kidney. You can see the kidney. This was a very enlarged kidney, so you could not even pick the liver that is usually next to the kidney. You can see there's a well-defined mass at the lower pole of the kidney, which was found to be renal cell carcinoma. Different patients, CT scans of the abdomen at the level of the kidneys. This is a patient who had bilateral renal masses. You can see the kidney well opacified with contrast, but you can be able also to pick a mass that is enhancing differently as opposed to the kidney on the left, and also a different mass on the right, enhancing differently from the kidney, and this was picked as a renal cell carcinoma. Advantage of CT, you'd be able to see the adjacent structures, whether there's any invasion. You'd be able also to pick any vascular extension of the kidney, which is a different stage for staging purposes. This is a different patient, axial CT scan of the abdomen, contrast enhanced. You can see the left kidney, but you can see the right kidney is enlarged because there's a mass occupying the entire kidney. You can see it's heterogeneous with an irregular outline. And at the same time, you'll be able to pick the fat stranding around the kidney, which was an indication of a extension into the perirenal fascia. So we go to another cause of hematuria, that's bladder tumor or bladder cancer. Cancers affecting the urinary bladder. TCC is the most commonest of the ones that you've seen. Others are squamous cell carcinoma, adenocarcinoma, small cell carcinoma, which is very rare. Clinical presentation, most commonly is hematuria, but the patient can also present with bladder outlet obstruction, especially if the tumor invades the urethral orifice. Diagnosis is usually made at cystoscopy with biopsy taken, and this is usually done even before imaging. If a clinician or a surgeon suspects a bladder tumor because the patient comes in with hematuria and maybe abdominal or pelvic pain, of course, the surgeon would want to do a cystoscopy, and at the same time, if they find anything, they'll do a biopsy. Role of imaging in bladder cancer is for staging. And at times, you might be doing a CT scan of the abdomen or an ultrasound of the abdomen and pelvis for any other pathology, and then you just pick a lesion around the bladder, which could be an incidental finding at that time because maybe the patient has not started presenting with hematuria. So early cancer is usually an incidental finding for bladder tumors. Ultrasound has a limited role in staging, but you'll be able to pick a suspicious bladder mass or bladder wall thickening when you're doing an ultrasound. This is a normal urinary bladder on sonography. I showed you the image. This is a patient who had hematuria with an ultrasound done of the bladder. You can see irregular bladder wall, but at the same time, you can see a mass protruding into the bladder lumen on the lateral aspect of the bladder. And it was actually vascular on color Doppler, confirming that it is a vascular tumor. CT scan, highly sensitive in diagnosis and staging of bladder tumors. It can replace cystoscopy in the diagnosis of bladder tumor. Just advantage of cystoscopy is that you can be able to obtain samples for histology. But for CT, of course, you want to be able to sample get the histological type. Main limitation of CT is that it's not able to distinguish the different stages of staging, whether it's T1 or T2, as opposed to MRI, which can easily do that. And that's why we say it's superior in locally staging the tumor as opposed to CT. So this is when MRI plays a very good role in bladder tumors. This is a CT scan of the pelvis, showing us the bladder filled up with urine. These are the pelvic bones, and this is a well-defined mass on the inferolateral aspect of the bladder. You can see it's taking up contrast, and this was seen to be a bladder tumor. Different patient. This is an MRI. You can see how clear MRI is. T2 weighted, fluid is white or bright. So this is urine within the bladder. This is the uterus. This is the rectum. But you can see a well-defined mass at the posterior wall of the bladder. Advantage of MRI, told you can be able to stage whether it's a T1 or T4 tumor because the bladder wall is very well seen on MRI, and any altered signal of this bladder wall will suggest you the stage of the tumor, whether it's a T2 or T3. Same patient, different plane. This is an axial. This is a sagittal. You can see the uterus just posterior to the bladder. Then urinary bladder well distended, but you can see a mass protruding within the lumen. You can see the signal of the bladder wall on that underlying the tumor is altered, and that was a sign that it's an extravesical tumor or it has extended beyond the bladder. Second pathology is bladder outlet obstruction. This is a clinical presentation arising from a number of conditions affecting the urethra or the bladder outlet. It's common in older patients due to prostatic enlargement. Other causes of bladder outlet obstruction are either urethral strictures of whichever cause or posterior urethral valves in pediatric patients. Clinical presentation is usually, of course, difficulty in passing urine. They can get retention or they get retention of urine and urinary discomfort. So we'll look at urethral strictures as a cause of BOO or bladder outlet obstruction. Scarring of the anterior urethra will result to luminal narrowing, which we refer to as urethral stricture. A common setting, it's common in the setting of trauma and infection, and the most commonest infection that we see causing urethral strictures is gonococcal infection, very common. Then in trauma, especially in patients presenting with pelvic trauma or pelvic fractures, usually they have trauma to the urethra or the bladder outlet or the bladder neck, so they'll present with strictures. Iatrogenic causes can be due to instrumentation, maybe during cystoscopy. You can injure the urethra at that time. Prolonged catheterization, you see patients who stay with catheters for a while, they can get secondary infection leading to strictures. Then post-prostatectomy, common cause of urethral strictures or a complication of prostatectomy is usually urethral strictures. Congenital, usually very uncommon cause of urethral strictures. So imaging, we usually do both ascending urethrogram and MCU, but ascending urethrogram is the primary method used to assess the anterior urethra, especially if you're suspecting penile urethral strictures, you'll just do an ascending urethrogram. For posterior urethra, you have to do a simultaneous MCU and retrograde urethrogram to determine the extent or the length of the stricture. Ultrasound has no role in evaluation of urethral strictures, but for pediatric patients, you can do a sonourethrogram, which is rarely done. Here you put saline or sterile water for injection through the urethra, and you distend the urethra. At that time, you're doing an ultrasound for you to be able to check out the caliber of the urethra when it fills up with the saline or water for injection. MRI has no role in urethral strictures, but it can be secondarily requested for evaluation of post-traumatic pelvic anatomy. That's a color-coded diagram showing how the male urethra looks. You can see the bladder, then you see the entire urethra. It's divided into 4 parts: penile urethra, bulbous, membranous, and the prostatic. Membranous and prostatic being the posterior urethra, then the anterior being the bulbous and the penile. Usually the most injured part is the membranous because it's next to the pelvic bone. So any pelvic trauma, it hits the pelvic bone and it gets injured. And actually it's the thinnest of all, as you can see even from the diagram. So easily tears, easily gets strictures, easily gets injured because of the position and the size. So this is an ascending urethrogram of a male patient, of course. You can see contrast has been introduced just at the penile tip. It opacifies the urethra all the way towards the posterior urethra, but ideally you want to evaluate the anterior urethra. You can see the entire penile and bulbous urethra is normal, but you get towards the membranous urethra, there's a narrowing, which was seen to be a urethral stricture. So here you can be able to measure the length of the stricture because that's what surgeons would want to do as they go repair. A different patient, MCU, showing the entire urethra post-micturition, but there's a narrowing not clearly seen because of the overlap of the bone and the position of the patient, which was also seen to be a urethral stricture. Ascending urethrogram showing the posterior urethra very well, anterior urethra, but narrowing of the bulbous portion of the urethra, very easily picked, easy to measure, and you can be able also to pick any extravasation of contrast. This is an MCU of a patient who had trauma to the pelvis and suspected injury to the posterior urethra. So we were not able to catheterize the patient at this point, but the patient had a suprapubic catheter. So we filled the contrast, we filled the bladder with contrast. At the same time, we pushed contrast through the urethra retrogradely, so that you can be able to opacify the anterior urethra, which you can see it was opacified very well, but there was a point of where the contrast could not pass. Then we asked the patient to try and pass urine, but could not pass because there was a tear or discontinuity of the posterior urethra, and we were able to pick the distance between the distal aspect and the proximal aspect, which was the region of injury, and we were able to measure. It was a very stenotic stricture caused by the injury. Posterior urethral valves, also known as congenital obstructive posterior urethral membrane. The commonest obstructing lesion of the urethra and a common cause of obstructive uropathy in infancy, commonly seen in male infants. Clinical presentation depends on severity of obstruction. Diagnosis can be made antenatally, luckily, on obstetric ultrasound. And here we usually see the fetus is small for age. We'll pick oligohydramnios on ultrasound. And we also are able to pick fetal hydronephrosis and a markedly distended bladder. Postnatal ultrasound on an infant, you'll be able to pick similar prenatal findings. That's a markedly distended bladder with fetal hydronephrosis. I mean, with the neonatal or infant hydronephrosis. MCU is the modality of choice for diagnosis of posterior urethral valves. Here you'll be able to pick a dilated and elongated posterior urethra. You'll be able also to pick vesico-ureteric reflux because of the chronic obstruction and bladder diverticular at the same time because of the chronic obstruction. Please mute your microphones kindly. I don't know who has their mic on. So the first image is a normal MCU that I had shown you before. You can see bladder with contrast, the urethra outpacified. Second image is a case of typical diagnostic case of posterior urethral valves. You can see the bladder, you can see the markedly distended or dilated posterior urethra. You can see there's a narrowing there. That's a membrane that we refer to as posterior urethral valves. And then you can see the anterior urethra. This is a diagnostic finding in posterior urethral valve, and MCU is the only imaging modality that will pick this. You can see the bladder outline irregular because of the chronic obstruction, and a few diverticuli being seen starting to appear in a case of posterior urethral valves. Infections, UTI, is a common clinical condition involving the bladder, which if it involves the bladder, it's cystitis. If it involves the kidneys, it's pyelonephritis. This can be either complicated or uncomplicated. Clinical presentation is painful urination, either bloody, dark, or cloudy urine. The patients also present with urine frequency, incontinence, and urgency, and they can also present with systemic symptoms like fever, chills, and rigors. Imaging is very unnecessary in uncomplicated UTI. When you suspect UTI, you just manage the patient on a course of antibiotics. Complicated UTI, we always do a renal KUB or ultrasound of the renal region. Disadvantage is that it's not as sensitive as CT in evaluation of the renal parenchymal changes in cases of pyelonephritis. CT is good in evaluation of renal parenchymal changes, and you can be able to pick the associated perirenal complications in complicated UTI or pyelonephritis, which could be abscesses. MRI, not primary modality, but can be used in pregnant patients because you want to avoid radiation. Lastly, we're going to look at vesico-ureteric reflux. This is abnormal flow of urine from the bladder into the upper urinary tract. Ideally, you're not supposed to have urine flowing back upwards to the ureters. It's commonly seen in children or in adults who have chronic obstruction as a reflex, the bladder, or the sphincter at the vesico-ureteric junction just loosens up so that you can be able to relieve the bladder from the chronic distension from obstruction distally. Reflux from the bladder into the upper urinary tract predisposes to recurrent infections, that's pyelonephritis. A diagnosis of VUR is suspected in a child with recurrent upper UTIs, which are unexplained. That's when you will suspect VUR. Clinical presentation is usually an isolated abnormality or associated with other congenital abnormalities of the kidney or the bladder. Primary modality of choice for VUR is MCU, where here we pick reflux in real time. You'll be able to see, as you tell the patient to micturate, contrast is seen going up towards the ureters, either bilateral or unilateral. You'll be able also to pick reflux either during urination, that's the time you're screening the patient or you're doing the fluoroscopy, or even during, if it's severe reflux, just the time you're filling up the bladder with contrast, you'll be able to see contrast refluxing towards the ureters. Can be able also to pick anatomical anomalies of either the ureters or even the bladder itself. Ultrasound is performed as a secondary modality to assess for renal scarring due to the chronic maybe irritation or chronic pyelonephritis due to reflux. Nuclear medicine and MRI ureterogram still not being commonly used, but initially were indicated. This is a case, the first case is an MCU. You can see contrast within the bladder, and you can see the patient micturating, but at the same time, you can see contrast going up towards the left ureter, and this was a case of vesicoureteric reflux. This is a pediatric patient. You can see the bladder poorly distended with contrast, but you can see the catheter. As the patient was being, as the bladder was being filled with contrast, you can see contrast actually flowing all the way to the calyces or the renal, to the kidney with dilated calyces, and this was a case of severe vesicoureteric reflux. A different patient as well with bilateral vesicoureteric reflux. You can see markedly dilated tortuous ureters bilaterally, contrast within the bladder, and dilated pelvic calyceal system. Local case, pediatric patient with severe VUR, MCU was done. As we were filling the bladder and the patient was urinating, you can see markedly distended ureters and the bladder. And the kidneys, marked hydronephrosis. This is a severe form of VUR, which is has a very bad prognosis to the kidneys. That's the last slide for the first topic. So you will read on BPH and prostatic hypertrophy around those topics. Then we can go to the next topic, which is very short. Then in case of any questions, kindly ask at the end of the presentation. The second one is the lymphatic system. So we all know that the lymphatic system is responsible for maintaining proper tissue fluid balance, the immune system, and absorbing lipids from the gut. It consists of the lymphatic vessels, channels, and lymph nodes through which immune cells maintain immune response. Disruption of any of these components, that's the vessels of the channels or the lymph nodes, would result in lymphedema or a local immune response, which we refer to as lymphadenopathy. This is a diagrammatic representation of the entire lymphatic components, or the components that that are part of the lymphatic system, all the way from the head to the lower limbs, including the appendix, spleen, and even the thoracic duct. So imaging, are going to look at different imaging modalities for the lymphatic system. We'll start with lymphoscintigraphy, which is basically a nuclear medicine technique to visualize regional lymphatic drainage. In lymphoscintigraphy, a radiopharmaceutical tracer is injected into the patient, and then the images are acquired with a gamma camera because they emit the radio tracer from the patient's body. Then the gamma camera will be able to pick that. Lymphoscintigraphy indications is lymphedema or mapping of sentinel nodes. I hope you know what sentinel nodes are. Ultrasound is also an imaging modality for the lymphatic system, but mainly for lymphadenopathy or splenomegaly. Rarely can ultrasound play any role in a case of lymphedema caused by disruption of the lymphatic system. MR lymphography It will help visualize and map the lymphatic vessels. PET-CT, also a new kid on the block, where nuclear medicine imaging modality has been combined with CT to provide metabolic and functional information, especially around the nodes. So mainly used for screening of nodes in metastatic disease or staging or follow-up of a patient known to have a tumor. So we'll start with lymphadenopathy, the first pathology. Lymphadenopathy is enlargement of lymph nodes, and it commonly depends on the location for you to be able to say that it's pathological enlargement. So anything less than 2 centimeters ideally should be insignificant, but I have said it depends with the location. If it's in the axilla and the inguinal region, up to 3 centimeters is actually insignificant because it could just be reactive. In the supraclavicular fossa, this is a very sensitive area. Anything up to 1 centimeter is significant. If you see a swelling on a patient at the supraclavicular fossa, that's a sign of a malignancy, either an intra-abdominal or even mediastinal malignancy. Causes of lymphadenopathy could either be reactive, neoplastic, or drug-induced. Reactive being in follicular hyperplasia or granulomatous disease. Neoplastic, of course, seen in lymphoma and metastasis. So for lymphadenopathy, ultrasound is the initial modality for evaluation of superficial nodes, especially in the neck, inguinal region, and axilla. Ultrasound will be able to evaluate the size of the lymph node, the number, the shape, contour, internal architecture, and vascularity. The shape, contour, internal architecture, and vascularity are very important for you to be able to differentiate between a benign node that is maybe reactively to infection or a malignant node from a non-metastasis or a non-primary or an unknown primary tumor. CT is usually secondary. Advantage for CT, be able to pick the primary cause of adenopathy because it's a cross-sectional imaging, so you'll be able to see the entire either abdomen or the entire neck as you are evaluating the nodes. On CT also you can pick the size, number, shape, contour, attenuation, and enhancement, just to differentiate between benign and malignant. CT is also used as a follow-up modality to assess treatment response, especially in cases of lymphoma or intra-abdominal malignancy with nodal metastasis. So you'll be able to pick the number of nodes or the size of the nodes. Then as the patient gets treatment, the patient is sent back again. You'll be able to check for response by the size, either decrease or the number which have decreased or increased. So these are ultrasounds of the neck region. Can see these are enlarged nodes. They have a reniform appearance. Usually nodes have a reniform or renal-like appearance, kidney-like appearance, because they usually have a central hilum and a dark cortex outwards, which we saw on a kidney ultrasound. That's why we say they have a reniform appearance. And this is a characteristic appearance of a benign node. If this type of appearance in an enlarged node is seen, you just confirm that that's a malignant node and not a benign. But ideally, an enlarged node with this appearance, central fatty hilum, and the dark cortex is usually a benign looking node. You can see here, there's another region, that's the neck region as well. You can see there's a lymph node that is very irregular. It has lost the normal reniform appearance, and this was a patient who had a tumor in the nasopharynx with a metastatic node around the submandibular region. CT scan, you can see this is a coronal image of the neck. You can see the cervical spine, but you can see multiple nodular masses bilaterally on both sides of the neck. This was a case of lymphoma in a patient who was found to have neck swelling or neck masses. Then CT advantage, you can count the number of nodes very easily, number one. Number two, get the size and attenuation of the nodes for you to be able to check out for treatment response when the patient comes back after treatment, because we'll just count the numbers again and the size of the largest node. This is a pelvic CT or a CT of the pelvis. Axial, you can see the inguinal region. These are muscles. But just adjacent to the muscle within the pelvis, you can see a very well-defined lymph node, which was thought to be a metastasis from, I think, prostatic CA. And you can be able to measure the size and even look at the attenuation on CT. MRI of a different patient with a node on the right aspect of the neck can be able to pick the size, the signal, and even the outline of the node for you to be able to tell whether it's benign or malignant. Lymphedema, second pathology. It's pathological accumulation of fluid in the soft tissues due to impaired lymphatic drainage. Can be primary or secondary. Primary is commonly hereditary or idiopathic. Secondary is due to obstruction or disruption of the lymphatic system, either at the lymph node level or the lymphatic channel level. Lymph node level can cause, secondary causes can be either iatrogenic in cases of radiation, patients who are undergoing radiation, either in the axilla or the inguinal region. Patients are undergoing surgery, maybe for nodal dissection, they usually present with lymphedema because of disruption of the nodes around that area. Tumors that actually metastasize to the nodes around the primary tumor will always cause lymphedema because of obstruction. Then lymphatic channel can either be iatrogenic during iliofemoral bypass, trauma around the lymphatic system, radiation, tumors also around the lymphatic channels will definitely cause lymphedema, and in infections like elephantiasis. Main diagnostic modality of choice, please note, is lymphoscintigraphy. Don't send patients with lymphedema for ultrasound. It won't help you. That's what I see commonly happening in the peripheries or in the outpatient clinics. Any patient who comes with lower limb swelling, you just send for ultrasound. Make sure you've made a clinical diagnosis of the cause of the lower limb swelling before you send for sonography, because it will be a waste of time to the patient. So lymphoscintigraphy will evaluate the major lymphatic channels, the nodes and function. MR lymphography is also very useful, but it's useful in preoperative planning, especially in cases of obstruction of the lymphatic channels, not the nodes. These are images of lymphoscintigraphy as they appear after the patient has been injected intradermally. Usually we inject between the first and the second toe superficially, because that's where we expect the lymphatic channel to start from. So we inject the radiotracer, that's sulfur colloid technetium. Then you wait for it to opacify. It will just opacify the lymphatic channels. It will not opacify the veins or the arteries. So what you see here on the image is the lymphatic channels on the right and on the left. After a few minutes, you will see it opacifying normal lymph nodes around the inguinal region, because that's where you expect the radiotracer to go. And after a while, you'll see it in the bladder because it has to be excreted. So these were normal lymphoscintigraphy images. Second case is a patient who presented with lymphedema on the left aspect of the lower limb, on the or the left lower limb. You can see the right limb post after injection of the radiotracer. You can see the lymphatic channel opacifying all the way to the lymph node, normal finding. But on the right, there was an obstruction. Sorry, on the left, there was an obstruction, which you see there's no opacification of any channel or the lymph nodes on that side. So this was diagnostic for lymphatic obstruction. MRI, good for now preoperative assessment, so that you can be able to map where the obstruction is and send the patient for surgery. So this is how lymphedema looks. Please don't confuse this with, you can confuse this with cellulitis, but there are clinical features that are very different. Cellulitis or DVT. Please don't confuse that based on your clinical findings. So these are MRI images of the left lower limb, actually bilateral lower limbs. This is the right, this is the left, and you can see increased signal within the subcutaneous tissues as opposed to the muscles. And this is the classical appearance of lymphedema, because the muscles are normal, but the subcutaneous tissue is full of fluid and it can easily be picked on MRI. These are standard MRI images, axial images. Then now we go ahead and now evaluate the lymphatic channels after you look out at the normal musculature. This is done on the machine. You can be able to do that, just subtract the soft tissues. You are left with the lymphatic channels only when you're performing an MR lymphogram. And you can be able to see this is a case where the patient had a swollen left lower limb. You can see it's more bigger than the right. The right, you can see the lymphatic channels actually picking up the contrast. But on the left, there's a disruption of the lymphatic channel at some point, and hence you see regular appearance of the collaterals that are trying to make up for the obstructed lymphatic channel, picked very easily. That's the end of the presentation. Any questions, comments? James, I will share the notes with the class rep. Thank you. Can see you say that. Any other question? Oh, Dennis Kimutai, can see your hand is up. You can unmute yourself. Do you have a question? Okay. Any other question? I will share the slides, as I've said, with your class rep, Moses, within this week or beginning of next week. Thank you. Have a good day.
Good day too.